Okay, well, it's noon, so let's go ahead and get started. On behalf of Michael Beeler, myself, and our guest Chief Resident from Emergency Medicine, James Cowell, I'd like to welcome you to National Journal Club, hosted by CMC. Briefly, we generally perform our critique and reviews using the 10-sentence abstract format, mostly focusing on the methods, results, and the implications. So with that in mind, we'll go ahead and get started with the first article. And today's theme is new or novel therapies for cardiovascular toxicity. So with that said, I'll let James, our Chief Resident, present the first article.
Hi, everybody. I'm going to be talking about the article titled Effects of BQ788 on Amitriptyline-Induced Cardiovascular Toxicity by Risi. Okay. Brief introduction. TCA overdose has significant mortality and morbidity that everyone is well aware of, and most of its cardiovascular toxicity may be mediated through the alpha adrenergic blockade, the norepinephrine reuptake inhibition, and sodium channel blockade. The impetus for this study is the fact that there is no good true antidote for TCA overdose. The idea behind this article is the use of endothelin, which is a powerful vasoconstrictor, and its effect is mediated through ETA and ETB receptors, whereas the ETA receptor mediates vasoconstriction and hypertension. The ETB receptor leads to vasodilatation through nitric oxide release and also enhances the clearance of endothelin. The objective of this study was to investigate the effects of ETB receptor antagonism by the drug BQ788 on amitriptyline-induced cardiac toxicity through the parameters of mean arterial blood pressure, heart rate, and QRS prolongation. The methodology for this study was to use a rat model and two separate protocols. The first protocol infuses amitriptyline until a mean arterial pressure drop of 50%, at which time the amitriptyline infusion is stopped, and then the rats are put into two different groups. The control group received a bolus of 5% dextrose, and the experimental group received a 10 nanomole per kilogram bolus of the BQ788. In protocol 2, the rats are actually pre-treated with one of the two arms, which is either the dextrose or the BQ788, followed by an amitriptyline infusion 15 minutes after the initial pretreatment. The results of the study from protocol 1 showed that after the infusion is stopped, when the bolus of BQ788 is given, the mean arterial pressure does initially increase with a significant difference between the BQ788 and the dextrose group within the first 15 minutes, and the BQ788 remains much higher than the dextrose level. Also shown here that the rats treated with dextrose have data points that end at 20 minutes, which was reflective of the fact that all the rats in that group died after 20 minutes. Similar trend for heart rate. After the amitriptyline infusion is stopped, the BQ788 is given. The heart rate does rebound and stays higher than the dextrose level. And similarly with QRS duration, the BQ788 treated group had shortened QRS duration as opposed to the dextrose group. In protocol 2, this is the pre-treatment with the BQ788 or dextrose. There is no difference between the two groups in terms of the MAP, heart rate, or QRS duration. Conclusions from this study showed that in protocol 1 that there was a benefit in the physiologic antagonism, whereas in protocol 2 there was no true pharmacologic antagonism. Clinical benefits from this study showed that there was a mortality benefit in this small population rat model, and as well as the reversal of cardiac dysfunction induced by amitriptyline by the BQ7088. However, the limitations from the study is that firstly, this is a rat model. Dosing and safety are not established for human models for this medication. Secondly, the theoretical mechanism from this article focuses largely on the fact that potentially the ETB receptor antagonism led to decreased clearance of endothelin and increased endothelin 1 levels, which were not measured in this case. And lastly, this is largely physiologic benefit as a pharmacologic benefit, which could mean that this is more supportive management than actually true antidote, and as an antidote effect. That's it. Any questions, comments?
Okay, hopefully we'll get this right with the hand raising and allowing everybody's input.
I can't tell if that's a hand up or not.
I can't either.
Detroit, if you've got a question, you can go ahead. Detroit, did you guys have a question? We're still working out all the hand raising and unmuting, so.
Not right now, thank you.
Anyone else? Oh, we got one. Just gotta figure out how to do it. I don't see it. There they are. Okay, so Rocky Mountain, go ahead.
Yeah, I was wondering, would there be any, I don't know, I guess it would have been nice to see a comparison to rats on a vasopressor or bicarb drip versus one of the kind of standard therapeutic interventions.
Yeah, I think that would be one of the next studies they would progress to use an experimental treatment against a fairly standard treatment, especially the bicarb.
Russ, do you think would you look at it as bicarb, or would you look at it as more of an adrenergic vasopressor? Because to me, this seems like it's sort of acting through the periphery, and I always sort of looked at TCA treatment as looking at the bicarb mainly for the cardiovascular effects, which it's certainly this ameliorated, but it also makes you wonder how much of the effects are due to peripheral at least some of it due to peripheral vasoconstriction, and maybe it'd be interesting to sort of parse out that mechanism by using phenylephrine or something that's more of a pure peripheral vasoconstrictor. Try and increase your coronary perfusion pressure. See if that's the reason that your cardiovascular effects are getting better, rather than just looking at going straight to bicarb, where we know we're primarily looking at the myocardium.
I think that'd be a very reasonable approach. I was kind of surprised that they got seemingly direct cardiovascular effects, especially with like the QRS.
Yeah, I noticed that too, and I thought that was sort of funny. And again, it makes you wonder if maybe some of it's just you're perfusing the myocardium better, and sort of that interaction between sodium channel blockade plus hypoxia, ischemia, and all the other bad stuff that we know goes on in the heart when you don't perfuse it well.
Yep, agree.
Maybe you should try a little insulin.
I don't know if it's ready for insulin yet.
All right, any other questions before we move on to the next article? Okay. Rocky Mountain, you'll have to put your hand back down and put it back up again if you want to ask another question, just to let you know, so we can keep track of all these hands. All right.
Oh, they have a question in Dallas.
You do?
Yep. They came in the Q&A.
Oh.
I'm just wondering, you think these rats were poisoned enough? I mean, the maximum QRS is about 150, it seemed like. And, you know, if we're looking for an effective antidote instead of sodium bicarbonate, because, you know, clearly some patients still die despite bicarbonate, you think these rats and other experimental models should be poisoned more?
I think it's probably, well, the fact that all the rats were in the control group all died, I think they were pretty sufficiently poisoned from that standpoint.
Oh, did you get that?
Yep.
Anybody else? All right, we're going to move on.
Okay, the next article is from the Western Journal of Emergency Medicine, dose-dependent response to cyclodextrin infusion in a rat model of verapamil toxicity. And I'm hoping that one or more of the authors may join us so they can tell me I'm an idiot or give us some better insight into their work. Quick background, cyclodextrins are currently used as pharmaceutical excipients. Depending on their binding property, that may modify solubility and delivery of some drugs. I put a structure of the particular cyclodextrin that was used for this study. I can't say it without getting tongue-tied, so I'll just refer to it as SBE cyclodextrin. But these compounds have a hydrophobic hydrophobic inner ring and a hydrophilic outer ring structure. And the whole idea behind these agents is that they will bind more hydrophobic drugs centrally, but because they have hydrophilic external rings, may be amenable to renal elimination. And they're currently used in a limited fashion on the market, not only to deliver drugs, but to remove drugs. For example, the authors mentioned Sugamadex, which has been used to reverse rocuronium. But the authors are utilizing the cyclodextrin as a treatment for toxicity, so they propose to bind the drug and then perhaps increase renal elimination. Now, these authors have done a previous model using cyclodextrin where they did a rescue model with verapamil toxicity in rats. Unfortunately, the cyclodextrin worsened the outcome. And because of some limitations in their model that included influence of the anesthetic, perhaps too large a dose, and high in osmolarity of the experimental treatment, they sought to repeat the study with some modifications in their model. And their aim was to test a range of cyclodextrin doses in a rat model of severe verapamil toxicity. And in this model, they modified some of their methodology to account for their reported limitations in the first trial. Okay, so they used rats that they purchased with indwelling femoral IV lines. They utilized an established LD50 dose of verapamil of 32 milligrams per kilo per hour constant infusion. And they utilized 5 treatment groups. Each group had 5 animals each. The first group was verapamil alone without experimental treatment. Then there were 4 groups of verapamil, each of which had a differing and increasing dose of the cyclodextrin. Their primary outcome was time to asystole up to a total of 60-minute experimental period, and they did appropriate analysis. Now, just to kind of compare to their previous to this current study, they thought that there may have been some respiratory suppression from the isoflurane. So in this particular model, they induced anesthesia with isoflurane, but then switched to ketamine and diazepam for maintenance of anesthesia. The previous study was a rescue model. They used a co-administration of toxin and treatment model this time, and their doses were aimed at molar ratios of 1:1, 1:2, 1:4, and 1:8 instead of 1:16 used in the original model. And this corresponded to a decrease from an osmolarity of the treatment from a little bit over 1,000 milliosms to around 300. They had pretty straightforward results. At baseline, there was no difference in heart rate, but in one group, the respiratory rate was slightly increased. Now, I don't know if that was clinically, a relevant significant difference. And then most importantly, their group 4, the group at the 1:4 ratio of verapamil to cyclodextrin had increased time to asystole versus control by roughly 3.5 minutes, and you can see the data pictured on the graph. There were no other differences in secondary outcomes, including heart rate or time to apnea. And they concluded that there was a survival effect at the 1:4 ratio or 564 milligrams per kilo cyclodextrin dose, and that this supports further investigations utilizing cyclodextrins for calcium channel blocker toxicity. Now, implications for the present study, the authors again list a quality list of limitations, including respiratory depression that may have influenced the results. They did not have hemodynamic monitoring. They may have not found some results in groups because of potential too small a groups, although we certainly found a positive difference in one of the groups, and that this was really not a mechanistic study to explain how this works. Additional limitations include the lack of an experimental control group, i.e. a group that did not get verapamil nor cyclodextrin to see how much influence the anesthetics may have had on apnea and survival. And because there was some difference in the respiratory rates, you might want to go back and ask, is the 5-minute stabilization period after induction of anesthetic sufficient to really make these animals stable before making them toxic and treat? And they did not mention any difference in total anesthetic doses that might have influenced outcome. And of course, this is a co-administration of toxin and treatment and not a rescue treatment. But it does make for some interesting potential future studies that may benefit from mechanical ventilation and hemodynamic or metabolic monitoring. And I'm sure that that was influenced by resources and cost of the study. And it would be good to repeat this study, or repeat the rescue study at the dose they found and thought was safe in the current study. Future implications, are there other dextrins that might work? Will this work for other calcium channel blocking drugs? They would certainly need to address adverse effects, but I think this is very intriguing to utilize an existing pharmaceutical product as a novel antidote, and I would venture to say that pursuing something like cyclodextrins would likely be much less expensive than developing immunotherapy. So with that, I'll open it up to other comments or questions.
Again, just put your hand up if you've got a question, or use the text Q&A and we'll unmute your line. All right, Dallas.
Hey there, Russ, you hear me?
Hey, Kurt.
Hey there. So my question I have on this is I'm looking at Figure 1. Is this is the simpleton in me here, and I sit here and I think about dose response. And so I'm looking at the top left figure relative to asystole, and all stats were done compared to controls. They were not done compared to individual groups. Everything was compared to control. So I'm trying to figure out why, if I think about typical dose response, why would I have a 1-to-4 ratio that was significantly different, but the 1-to-2 wasn't, and the 1-to-8's not? And so I'm looking for some sort of a pattern that I'm just not quite seeing there. And I mean, and the same thing applies as I go down to the bottom right figure on respiratory rates. Now here, there were significant differences from the control with the 1-to-1 and the 1-to-4. But then why would there be no difference for the 1-to-2? And that part just doesn't make sense to me from a dose response aspect. And so I have to wonder if this variability is more related just to small number sizes. And so, certainly, because you look at the stats for that they have at the bottom in the text that goes with the figure, I mean, they're very wide confidence intervals, as you would expect with such a small number of animals that were involved. I mean, and you go back, even look at the apnea, time to apnea, which is the top right figure. And here, none of them were of statistical significant difference from the control, but it looks like some of them were of statistically significant differences between themselves, like that 1-to-2 ratio was certainly looks significantly less than the 1-to-1 or 1-to-4. Once again, all goes back to the concept of dose response, and I'm just not quite seeing it there. And so I was hoping Sean and or Steve was going to be on here to discuss their thoughts on that. But I have to say, right now, I'm not real impressed with this, and I'm not, it'd be a lot cheaper than other options, but I'm not sure if I'm sold in the data here that I see that find that interesting to move forward on. So, anyways, those are my thoughts.
Okay, I think the guys from Chicago have joined us, so we'll let them.
I just got them unmuted, and we'll get the Rocky Mountain fellows in a second.
Hey guys, Steve Axe here. Can you hear me?
Yeah, go ahead, Steve.
All right,
Thanks for joining us.
Great. Yeah, actually, Sean's out of town, and Alan is up in Madison working a clinical shift, so I'm here. Russ, at first I want to tell you that you did a very intelligent job describing the study. So good job. Yeah, and actually, Kurt, those are great observations. And like a few things. Again, this was the second study. I think in the first model, what we were really concerned about was the high osmotic load. So we really think that we just kind of blew it in the first study because we think that it was just such high osmotic load that they just wanted to arrest so quickly. So what we were doing in this study was playing with the dose to try to find a dose that might show some effect. And Kurt, you're right on the money. Like, I think a lot of those clinical effects are just, we're not looking at dose response, it's more small sample size effect. And if we could do a third study, we really would want to look at that 1-to-4 ratio in ventilated rats. Russ, as you mentioned, it was definitely a resource issue. I think for us to pull off the next step, we would need the money to go ahead and actually ventilate the rats so that we can see if there's an effect. I mean, I think it's really a fascinating idea. These cyclodextrins are used for delivery systems for pharmaceuticals every day. It's just, this seemed like a perfect choice because there's actually a lot of bench or basic science pharmaceutical research that shows that it fits together with the molecule quite nicely. So, we were actually very excited that we saw any effect in terms of time to survival. But the observation in the lab was that this apnea phenomenon, if we could actually take that off the table, that really would have been useful.
Okay, thanks, Steve. I think we'll get Rocky Mountain and then Dallas next.
Hey, Rocky Mountain.
Hey, Michael, it's Kenan again. So I thought, Russ, I just wanted to make a quick comment on Russ's note about immunotherapy. And we did a very small in vivo study several years ago that was an academic EM, and we actually had some effect using an antibody fragment against verapamil when we pre-mixed it. and that ended up being in the manuscript, and then we actually did publish a follow-up just as an abstract when we tried it in a post-treatment. So we poisoned these muscle strips with verapamil, and we tried to then use the antibody after we had established toxicity. We really couldn't get any effect. So I'm almost worried that verapamil, it's really tough to use any type of binding, at least from what I've seen based on this study and what we did. It's really tough to find anything that's going to effectively reverse the toxicity by binding up the drug, and I think the work that you all have done with the metabolic therapies is probably a much more promising way of treating these.
Interesting.
Any other questions from any of the groups?
Oh, Dallas.
Oh, Dallas. So Dallas.
Hey, Steve, I'm excited to see you and Sean involved in this work. Now, I'm curiosity. So, how's the funding working for this?
You mean you want our secret, huh? We actually.
How about your secret? Is it lemonade stands, or what are you doing there, man?
Yeah, no. We actually had some seed funding through our Department of Emergency Medicine, so that's how we were able to do that. And and also, Ken and I think you raised a great point. Again, this is more, the cyclodextrin is not really immunotherapy per se, as you know. And what Alan is really interested in looking at up in Madison is really the effect with lipids and lipid bilayers, and if there's some interaction there. I really agree. I'm not so sure that this will be the magic bullet. And I think really what Alan is going to be pursuing, which I think is fabulous, is how does lipids work? I know we keep talking about this lipid sink phenomenon, but I suspect and I wonder if there's really more a lipid layer interaction. So I think we really need to do research more in that area. I think Ken and I really agree with what you're saying. I think to actually engineer the right binding agent is going to be really tricky for verapamil.
And what's in their hands?
I think everyone's hands. All right. Any other questions from anybody? All right, then we'll move on to the final article. Which is entitled Extracorporeal Albumin Dialysis in 3 Cases of Acute Calcium Channel Blocker Poisoning with Life-Threatening or Refractory Cardiogenic Shock. And so this article is a small case series dealing with a pretty significant calcium channel toxicity in 3 patients. And it features around the use of this molecular absorbent recirculating system, otherwise known as MARS. And because I didn't think that everyone was all familiar with this, because I wasn't before we got into this, MARS is actually a sort of double dialysis circuit where you've got a hemodialysis circuit, and then sort of piggybacked onto that you have an albumin circuit. And the way it works is that there's this relatively special membrane on the hemodialysis circuit that it's been impregnated with albumin, and it allows basically this exchange of albumin across this membrane, and then the albumin circulates in this secondary system. And this secondary system then puts the albumin through a charcoal filter and then puts it through a resin filter to sort of regenerate the albumin. And this is necessary because you could have just run albumin as a countercurrent in hemodialysis, but then you'd end up flushing away all that albumin, and it just would become prohibitively expensive. And this system basically then regenerates the albumin, sort of puts it through and back, and is able to recirculate during that time. And interestingly enough, as you do this, especially in someone who's got hepatic failure, that nice white resin will start to turn sort of a sickly greenish brown as time goes on, sort of demonstrating the removal of these things. So in this case series, and this is a group that's in France, and they're trying to determine a better treatment or some treatment addition to what we do with our sick calcium channel blockers. And we know, as we've been discussing, and we know these are all relatively difficult to treat. And we've tried insulin glucose, there's glucagon's been used, and then more invasive, the intra-aortic balloon pumps have been tried. And we've all had patients that have died despite our best efforts, and so we know these aren't perfect. Now, we try hemodialysis for certain toxins, but they're not going to work with calcium channel blockers, and I put up some of the statistics on diltiazem. You know, greater than 3/4 of it, at least at therapeutic doses, are protein-bound and has a relatively high volume of distribution, which really strikes against you being able to remove any with normal hemodialysis. But we know that MARS can remove protein-bound toxins, and so the question is, if we're going to try using MARS in this overdose picture, will it improve clinical markers in overdose, and could it potentially reduce diltiazem and verapamil levels? So this is a case series of 3 patients that have a calcium channel blocker overdose. They describe an amount that they were ingested, but they don't really describe how they got to that number. There are 2 patients that overdosed in diltiazem and 1 on verapamil. They do a pretty decent job describing that these patients are sick initially. They describe, hypotension, they're bradycardic, they are getting these transthoracic echoes and demonstrating a deficiency in their ejection fraction. They're doing verapamil levels as well as diltiazem and diltiazem metabolite levels. And they do point out these levels were done after all the show's over, so they weren't changing their management, but it's useful for us to figure out what was going on. They're looking at the arterial pH, they're looking at serum creatinine, they're checking mean arterial pressure, and they're looking at total, trying to adjust the total pressor dose. And so all of these individuals, while they're have gotten a bunch of different therapies, including glucagon and the insulin glucose therapy, they put them on the MARS for 6 hours for one of them and 4 hours for another one. And the charts I tried to reproduce, and I had some software issues, but they're on page 3 there, and you can see that they've grayed out the area where the MARS therapy was going on, and pretty much it looks, at least on first glance, like there's some positive benefit. All 3 cases survived, and all of them, I think they did a pretty good job demonstrating that they had clinical illness prior to initiation of MARS. They all had left ventricular dysfunction. They all had hypotension that wasn't responsive to reasonable doses of pressors. They all had increased creatinine. To put things in perspective, the highest level of creatinine was 3 milligrams per deciliter in the non-SI units. All the other ones were lower than that. So they all were sick. They all get MARS. They all improve. They all have their mean arterial pressure that improves. Their serum lactates fall. Their vasopressor doses drop in 2 of the 3 patients, and then the 3rd patient, it does fall soon afterwards. They demonstrate a falling of diltiazem and the metabolite after dialysis as well. In fact, case number 3 had a verapamil level that, at least according to the authors, and I didn't have a chance to pull it, was the highest reported with survival. And of course the question then is, did MARS help with the survival, or was it just youth and luck? Since, actually I'm sorry, I thought that was case 2. But also of note that if you look at the diltiazem, the metabolite of diltiazem in case number 1, the metabolite actually climbs during the MARS therapy. And they also say that there's no complications of the MARS therapy. And along those lines, though, they don't go into details about did they anticoagulate, which is actually a significant issue because when you're dealing with MARS, a lot of times it's being used for hepatic issues in people that are already coagulopathic. But one of the bad things that can happen with MARS is you can clot your circuit off. And it won't necessarily kill the patient, but it basically means the end of your therapy, and you have to basically start over with a new kit, more albumin. And they don't really detail whether they did or they didn't do that. Some other limitations to this study is that they didn't really perform standard therapies. I think most of us would argue that a 2 milligram dose of glucagon is really not even a college try for someone who's really sick from a calcium channel blocker, and none of them really get significant doses. And they don't talk about the dose of the insulin glucose. They just say that it was done. But given if the glucagon dose being that they thought is sufficient, I would be a little bit questionable. And we all know now that the dose of insulin that we can use for these calcium channel blocker toxicity cases, people have used more than 1 unit per kilo, and even as many as 10. And so we'd like to know more about that. most important, though, is we really don't know the clearance of the diltiazem or of the verapamil by the circuit. And in some of these cases, the levels were falling already. And then with patient 1, why did the metabolite level go up during the time of clearance? And you could say, well, they were metabolizing diltiazem and that made more of the metabolite. Okay, that's true. But then you'd think that you'd at least be keeping up with the clearance of that during the procedure, and you weren't. So the conclusions with this are that MARS therapy might have a role in diltiazem and maybe, well, only with one, verapamil toxicity. We're really going to need to know more about exactly what role MARS played in this, because did it remove the drug, or was it a correction of the acidosis along with the hemodialysis that allowed just better cardiac function? As mentioned before, it may be the whole constellation of acidosis and other electrolyte disturbance along with the drug that's causing a problem. Could have been removal of some other inflammatory factors, as we were discussing earlier, some of these other things that get pulled off in this process. What role did they play? And most importantly, MARS really would not replace standard therapies. And so before we get on to questions and comments, I did want to kind of flesh this out a little bit. The MARS therapy does have an FDA indication in the United States, so it is possible to perform it. Interesting, it has an FDA indication for poisonings, even though the data on its use in human poisonings is really kind of limited to what you just saw or read, because there really aren't a lot of case series. There's a little bit more with some mushrooms, but really not a lot to go on. Interestingly, the more data is actually on hepatotoxicity and bridge to transplant, but it doesn't have an indication for that at all. But just to kind of sort of ground it and realize that there are actually some groups here in the United States that are using it. And so hopefully, in time, we'll get some more data on this. Questions?
Questions and comments?
All right, Toxicon, you're on. Or did you forget to put your hand down?
I forgot to put my hand down, but since you're giving me the green light, I do have a question. Is anyone on the call here actually using these MARS devices? I know at Rush, we've had discussions using this for a liver assist for acetaminophen. But it does. I think this study raises fascinating possibilities in terms of one assist, but really what is the clearance of the drug, if any? So I'm curious, is anyone else using this?
Put up your hand if you've got any info. I can tell you that at our institution, we were angling to try to get it to be used. And again, it does have an FDA indication for poisonings, but it's a very bizarre situation where the data is actually better on sort of hepatic failure. But it has, even more bizarrely, a contraindication for use in hepatic failure that's not in poisoning in origin. And so it's a very strange situation to try to justify its cost. And although apparently the cartridges are only a couple $1,000s each, $3,000 for a treatment, you've got to supply the human albumin, and then you also have to supply the training to get the people to be able to use the machine, and you got to be able to get them on the circuit as well. And so it isn't as expensive as some of the things, a full course of CroFab, for example, but to be able to do this, it's actually the training which sort of gets in the way. And so we've run into the problem of the almighty dollar, and we're in hold right now here. Anyone else have any experience or comments? Or?
All right, any other comments or questions about the last article? If not, we'll conclude the proceedings, and I'd just like to thank Michael and James for assisting with article selection and reviews, and thank all the participants, and Steve for heading up the National Journal Club effort.
Thanks, everyone.